everybody. Welcome to the May 2025 edition of the European Urology Podcast. My name is Declan Murphy, urologist here in Melbourne, Australia. And I'm joined as ever by my co-host, Dr Nikita Bhatt, who's a urology fellow in Newcastle at the Freedland. Hey, Nikita, how are you?
I'm very good. Declan, how are you?
All good, all good. This is the time of the year where I begin to feel the seasons a bit. Down here in May in Australia, it's beginning to feel a bit wintry. Not wintry by Northern European standards, whereas up there in the UK, rest of Europe, you're beginning to feel positively spring-like or even summer-like. So how's it been for you?
The weather's been really nice. I can't complain this time. So no, it's been amazing. Really enjoying the good weather and being outdoors with my children. So it's been fab.
Very good. And how are your little twins? Are they behaving themselves?
Never, but they're all right. They're all right. They're cheeky monkeys, but when they're naughty, but you wouldn't expect anything less.
Yeah, you think you're busy, and then you chat to young mums and dads with twins or triplets and stuff like that. So I'm a few years beyond having not twins or triplets either, mind you. So yes, well, I hope they do behave themselves and have a great summer. So look, it's been another cracking edition, of course, of European Urology. As ever, it's a struggle to try and pick out the highlights, but we have picked out two good papers this month. So coming up, we have, first of all, a chat with Steve Freedland, Dr. Steve Freedland, urologist at Cedars-Sinai Medical Center in Los Angeles, who's the PI on the EMBARK study, a very important study of the role of hormonal therapies in high-risk biochemical recurrent prostate cancer. It was a big paper in New England Journal 2 years ago, but this is a post-hoc analysis of some really interesting components of that published in the journal this month, looking at sexual side effects of the three different arms in the study, particularly the enzalutamide monotherapy arm. So stay tuned for that chat with Steve. And then Nikita, you're going to go and chat with Professor Grant Stewart, a urologist in Cambridge, about this very interesting screening study for renal cancer. It's called the Yorkshire Kidney Cancer Screening Study. So that should be a good chat. You're looking forward to that?
Yeah, absolutely. And I used to work with Professor Stewart while I was a trainee. So I'm really looking forward to seeing him again on virtual platform, but it'd be nice to chat with him. Yeah.
Yeah, that's really good. So, we don't screening for kidney cancer. That's not a big, hot, contentious topic. Not a lot done on it, but this is a very interesting trial. So stay tuned for that if you're interested in kidney cancer. Well, indeed, this applies to all of urology because we're talking about screening. So it's a very interesting thing. And then finally, we give out some awards every year in European Urology. We tend to give them out at the EAU meeting. And one of the award winners, Dr. Laura Elst from Leuven, joined me for a quick chat about her paper, which won the award for Best Translational Paper in European Urology last year. So yeah, lots of good stuff to look forward to. We'll dive right in and we'll go to Los Angeles and talk to Steve Freedland. So it gives me great pleasure to go over to Los Angeles now and join my old friend, Dr. Stephen Freedland, urologist at Cedars-Sinai Medical Center. Stephen, thanks very much for joining us on the European Urology Podcast.
No, thanks so much for having me. Really appreciate it.
And of course, congratulations on this new paper from the EMBARK study published in this month's edition of the journal. Now, look, for any of us working in prostate cancer, especially localized prostate cancer, the EMBARK study has been a pivotal study. It's been one of the most important studies that has read out in the past couple of years for me personally in my clinical practice, looking after a lot of men with high-risk localized prostate cancer. I'll ask you in a second to just briefly remind us about the EMBARK study and that really exciting paper that was published in New England Journal just less than 2 years ago now, which is still rippling around the world. The impact of that trial for clinical practice around the world is still rippling as we get the reimbursements and so on. And then very importantly, this particular brief update from the trial, which is looking at sexual activity in patients on the trial. First of all, please remind us a little bit about the EMBARK study before we dive into this update you've just published.
Absolutely. And I first want to give a shout out to Neil Shore. I'm the co-PI, many investigators around the world, and obviously great support from Pfizer and Astellas to get this done. So the EMBARK trial was patients with high risk, conventional imaging negative biochemical recurrence. So it had surgery, radiation, and the doubling time was now less than 9 months, PSA doubling time. And they're no longer candidates for salvage radiation, and so you're ready to do some sort of systemic treatment for these patients. And You know, historically that's been ADT alone, but we know in the metastatic setting that we can improve upon that by adding enzalutamide. So that was the question here: is can we improve upon that by adding enzalutamide versus ADT alone? And a third arm that was actually just enzalutamide alone. And the primary outcome was metastasis-free survival. So metastasis or death, which has been shown to be a surrogate of overall survival. And what we found was that enzalutamide, either with or without ADT, delayed metastasis or death. And importantly, in this population of relatively asymptomatic patients, they don't have metastatic disease, they don't have a lot of burden from the cancer, we preserved the quality of life for these patients, very importantly.
Yeah, look, it's really important, isn't it? And because these are a group of men, as you say, they're not ones who are going to get some salvage radiation. They've already had that, or they look like candidates who need systemic treatment. The PSA is above 1 after a prostatectomy. The PSA is doubling quickly. Conventional imaging might be negative, but we know it's not going to be negative for, more than a couple of years in the future. So that was very exciting for us to see. You can really push out that metastasis-free survival. And I know the data is still being analyzed for overall survival, but of course we're excited to see that as it matures in the coming time. But look, what it's led to is approvals in Europe and in the US for enzalutamide, either, as you say, in combination with ADT or as monotherapy. And so that's very important. And that message is still getting out around the world. In fact, we had you on GUcast, our mothership podcast for this podcast, not that long ago, here in our studio in Melbourne, diving into that in great detail. So I will actually link to that in the show notes as well. So onto this update you've just published, and we don't have time, of course, to go to this in great detail today. We're linking to the paper in the show notes, so we really want people to go and look at it. It's actually one of our short updates in the journal. It won't take you long to read it. But this is very interesting because one of the potential benefits of enzalutamide monotherapy, in particular for this group of patients, which is not a clinical practice that we've explored in other areas of prostate cancer. This is kind of a unique experience, is that it may have a different impact on sexual activity for patients compared to having ADT alone or ADT with enzalutamide. So the title of the current update is Effective Enzalutamide on the Sexual Activity of Patients with Biochemically Recurrent Prostate Cancer, a post-hoc analysis of the patient-reported outcomes. So tell us a little bit about this then, about what you've explored in this paper and what you found.
Yeah, I mean, it's an important question. If we look at enzalutamide monotherapy, you could argue the efficacy might not be quite as good as combination, still better than ADT. If we look at overall number of side effects, just adverse events, grade 3, 4, it looks pretty similar. There's some differences in the type of adverse events. So you could say, well, why would I go on monotherapy? What's the advantage? And to me, that's what we kind of hypothesize is you still have testosterone floating around because you're not castrated. If anything, the testosterone doubles and goes up. So you have plenty of testosterone, gets converted to estrogen. Both of those are important for libido, which we still don't, at least I don't fully understand what's all involved in that. I'm sure there are a lot smarter people who do fully understand that mechanisms. But so that was one of our hypotheses, was maybe we're better preserving sexual activity, libido. And we had some hints of that in the primary PRO, but we really dug into that in detail here and looked question by question. When you do these patient-reported outcomes, you ask a lot of questions. We often look at the big domains. 3 or 4 questions make up a domain. But here we went into the individual specific questions. And importantly, we focused on those who were either sexually active at baseline, which was 40%, or interested in sex at baseline, which was 60%. So remember, these patients all had surgery or radiation, or in many cases, both. And so not always sexually active, median age of 70, which means half the patients are in their 70s or 80s. So they're not as interested as a younger patient population, but still 60% interested, 40% active, which is, to me, interesting, the 20% that's interested but not active. But nonetheless, what we found, importantly, is that enzalutamide monotherapy much better preserved that sexual activity relative to ADT alone. And again, it's not going to make your sexual activity better, So we looked at time to decline in sexual activity, because 70-year-old men getting older, things are going to decline with time. But it was much, much better preserved, longer time to those declines, meaning for the patient that really does value that sexual activity, this is, I think, a good option for those patients.
Yeah, look, it's quite remarkable. And I do like that endpoint, the TTCD, the time to clinically meaningful deterioration, as you say, acknowledging this is an aging population of older men who've already had a lot of treatment down around the prostate. So there is undoubtedly, Steve, a very distinct proportion of patients that we all have in this situation who've done well, but their PSA is rising quickly, so we and they are worried about the potential for metastases and death from prostate cancer because they're otherwise well. But on the other hand, if they are still, as you say, sexually interested or sexually active, we know there's a significant price to pay for going on ADT. So for me, that's a really distinct advantage of having this here as an option for our patients of enzalutamide monotherapy. So it definitely changes that conversation, doesn't it? Rather than saying, okay, look, we're going to have to use ADT or ADT plus enzalutamide for even better response. But there's a distinct proposition for patients to say, if you value this and you're still going to do better than ADT alone from a cancer point of view, enzalutamide monotherapy is an important tool to have.
Absolutely. And we make these trade-offs all the time. Yeah. And if you think about it, active surveillance, it's not better treatment for the cancer, right? It's not possible that doing nothing is better for your cancer than doing something. And we accept that there is probably a little bit of risk, particularly as we push active surveillance to Gleason 3+4, grade group 2, a little bit more tumor volume, but it's the quality of life benefits of active surveillance that have driven that, right? So here we have a treatment, okay, it may not be as good as combo, but clearly has some quality of life benefits that are going to be important to a subset of our patients, not all of our patients. And it's not necessarily age. I have, maybe this is Los Angeles, but I have an 81-year-old who is potent despite his surgery and his radiation. And that's super important to him, and was excited at the concept of monotherapy, that we could better preserve that for him and his partner while still having good cancer control.
Totally. Now, I think I must ask you about briefly is you mentioned that side effects are different when you're on enzalutamide monotherapy, and you've already gone through this in great detail in the main paper. Is this rather specific issue of gynecomastia for these patients? Just from a clinical practice point of view, just a tip for us out there, I suppose, potentially using enzalutamide monotherapies. How do you deal with this? How do you deal with the idea that a distinct proportion of patients, if you're on enzalutamide alone, will develop some gynecomastia? Do you deal with it up front by putting things like radiotherapy in up front, or just wait and see?
No, you definitely want to do it up front. Yep. If you wait and see, they've developed the gynecomastia, and you can't easily treat it at that point outside of surgery. So you do need to be prophylactic about it up front. I'm a huge believer in irradiation. It's 1-2 doses of radiation, minimal side effects, and really can be quite effective. There's certainly data on tamoxifen as well. Talking to people anecdotally, the literature would suggest more than 20 milligrams daily, but I know anecdotally people have done as low as 10 milligrams every other day, still with very good responses. I'm kind of a belt and suspenders guy type thing. So to me, it would be radiation and tamoxifen, but I think you can make an argument for either or. Yeah.
Terrific. So look, this is very exciting, and this is the only ARPI, to my knowledge, that's approved in this high-risk biochemical recurrence setting. So it is a rather unique option for patients. But a question that'll come out of this is, because of this specific benefit that you're reporting in this paper on sexual activity, Steve, is, what about ARPI alone? Patients will ask us this question with low volume MHSPC, maybe even on a PET scan, that they've got metastases, whether it's up front or recurrent, and they're young, they're sexually active, they don't want to go on ADT. What are your thoughts, because this is not an approved indication, but just as a clinician, for the role of an ARPI alone like enzalutamide in MHSPC, maybe low volume?
Yeah, I think, as you alluded to, it's not approved. Yeah. We don't have the data, right? So this is just all opinion based. There is a trial going on, Libertas trial, looking at apalutamide and those that got a good response after a period of time, dropping the ADT and leaving them on apalutamide alone. There's a lot of interest. There's some trials going on more in the BCR setting. I'm not opposed to it. I mean, especially for the low volume patient who's going to be getting metastasis-directed therapy, who's going to get prostate-directed therapy. Again, you have to discuss the uncertainty. We do know from EMBARK it's probably not as good as combination, but these are patients now, a couple spots, particularly, if it's PSMA only positive, then that's kind of a more EMBARK-like patient anyway. But even conventional imaging, a couple spots, these patients now can live 10, 15 years, do really well. They're throwing the metastasis-directed, and that's a long time to be castrated. It's a long time.
Totally right. So more work in RP alone, I think, is one of the messages that's come out of the EMBARK study, and especially with this update. Well, look, congratulations again, Steve, to you, Neil Shore, and all the investigators in EMBARK, and of course to all the wonderful patients who participate. The full paper is in this month's edition of European Urology, and we'll put a link in the show notes. Thank you so much again.
Great. That was really interesting, Declan. So what messages do you think you would give to anyone looking after biochemical recurrence in prostate cancer in terms of ENZA monotherapy?
Yeah, look, well, two messages really. First, the main messages from the main EMBARK trial that published in New England Journal 2 years ago is that in this group of high-risk BCR, that means the PSA is doubling quickly every 9 months or so, adding enzalutamide to ADT, which we would consider a standard of care, or enzalutamide on its own, is better than ADT on its own for reducing metastases. So that's already a key message that we're still rippling out, I suppose, across the world if you have patients in that setting. But second, on the point of enzalutamide monotherapy, because look, we don't like putting patients on ADT, especially younger, fitter patients. ADT, it's a bit of a miserable experience, as we often discuss on GUcast, on our main podcast. So if we can give some good oncological benefit using ENZA on its own, which is what EMBARK has shown, plus there's this specific group of patients that we just spoke about in whom sexual activity can be preserved better than with ADT, then sure, that's exciting for us. Now, it's still early days for this data. I mean, the role for the registration of enzalutamide for high-risk BCR is now already there in Europe and in North America and here in Australia, and it's rolling out across the world. But we still, as a urology and radiation oncology population, are getting to grips with it, and we don't have full reimbursement around the world yet. But I think it's a really important paper, Nikita, the EMBARK trial. If there are trainees and those out there who are not familiar with it, you should go and be familiar. It's a pivotal trial in urology. And on GUcast, we've spoken about it a lot. But I think Steve's chat just now shows us that RP monotherapy, enzalutamide monotherapy, is very interesting because it has a different set of side effects to adding in ADT.
Absolutely. Makes a lot of sense even to people who don't manage prostate cancer. So definitely go and read the paper. I think will definitely hopefully change practice in the future, like you said.
Exactly. And the link to the full papers in the show notes as ever. But let's cross now to your discussion with Grant Stewart, Professor Grant Stewart, about this interesting kidney cancer screening study.
Well, so joining us for our second segment today is Professor Grant Stewart from Cambridge, who I previously worked with, and it's my pleasure to invite him today. I'm sure he needs no introduction, and everybody is very well aware of his amazing work, but I will let him introduce himself before we jump on to his paper.
Thanks, Nikita. Lovely to see you. Yep, Grant Stewart's my name. I'm Professor of Surgical Oncology at the University of Cambridge, and I'm a consultant urologist there.
Brilliant. So the paper that is published in this month's European Urology, could you summarize it briefly for us and let us know what are the kind of highlights of that paper for our audience, please?
Yeah, sure. So early detection of kidney cancer is something we've been working on one way or another for about the last decade. And the question that have ultimately led to this study is something that comes up every Monday in my clinic, which is people with kidney lumps identified by chance asking, why is there no screening approach to look for these things? So after a lot of pre-work that we did around this topic, including asking a lot of members of the public what they think about the possibility of screening for kidney cancer, we undertook this study called the Yorkshire Kidney Screening Trial, where we were looking at the feasibility of adding a CT scan of the abdomen onto the CT scan of the chest that is done in lung cancer screening. So these are people who are smokers or heavy ex-smokers who are eligible for lung cancer screening. And essentially what we did was we asked them when they turned up at the screening unit expecting to have a scan of their chest, if they would also be interested in having a CT scan of their abdomen. The primary endpoint of this study was feasibility, so would people agree to have it done? And in fact, 93% of people that we invited on the day of their CT scan for the chest agreed to have their tummy scanned at the same time. The other two things that we were very interested in doing was identifying whether people were satisfied with the process and what healthcare professionals thought of it. So of the 4,020 people that we scanned, we had really high levels of satisfaction. Even people who had an abnormality identified where you might anticipate there's a bit of anxiety or such like about what was going to happen next, had a very high level of satisfaction of around about 96%, very satisfied. Healthcare professionals found it quite an easy process. Of course, the other thing that we were very interested in is what would we find when we scanned a large number of people. And so the prevalence of findings were very interesting to us. So overall, of the 4,020 people that were scanned, 5.3% of people had what we defined as a serious abnormality. So these were findings that could be life-threatening, could significantly reduce your quality of life, so range from cancers to aneurysms to large kidney stones. When we drilled down into that detail a bit further, we found that 0.25% of people had a new histologically proven kidney cancer. 0.25% of people, exactly the same number, had a new proven other cancer within the abdomen. And a finding that was kind of surprising, although maybe shouldn't have been, was that 1.5% of people had a new abdominal aortic aneurysm. So we didn't know about that beforehand. So all of that detail is in the paper, and there's quite a lot of other information there. But essentially, we showed feasibility, acceptability, and quite a high prevalence of findings, and that's leading to further work in this area.
Brilliant. That's really interesting. So you've mentioned that the detection rate for renal cancer was 0.25%. Does that mean to make the number needed to screen over 400 from the paper? Is that, you think, good enough to justify mass screening?
Yeah, no, so good question. And obviously these numbers seem on the face of things quite small. So there's a few things to point out with respect to that, the number needed to screen, if you like. So the first thing is that even the absolute numbers of kidney cancers that were found, and here we are not talking about people with renal masses that we don't know what they were. We're talking about people that either had a biopsy or had an operation, and we got some histology. Even those numbers are slightly higher than some existing national screening programs. So in the UK, for example, bowel cancer screening has a lower prevalence than what we found for kidney cancer within YKST. But I think the other two key elements to flag are that ultimately, although we started this work looking for kidney cancer, we found a lot of other important, serious, life-threatening findings in the abdomen, other cancers and aneurysms. Abdominal aortic aneurysms can be very lethal, as you know. And so that all put together meant that if you took cancers and aneurysms as the most sort of serious findings that we found, you only need to screen 50 people to identify one of those things. So I think that brings it much more, actually very high up in terms of prevalence compared to other screening approaches, sort of just above what you would expect for breast cancer screening, in fact. The final thing, which isn't in this paper, but we've just had a paper accepted for the British Journal of Cancer, is around the health economics of all of this. So, of course, the other side of the coin, which I haven't got into, is the prevalence of things we didn't really want to find. So cysts in the kidney, small kidney stones, anatomical abnormalities, which just potentially create extra work. So when we totted up when we got health economics experts to look at the serious findings versus the incidental findings that we didn't want to find, the cost of the screening process versus the potential cost of serendipitously finding kidney cancer and these other abnormalities as we do currently, this is an economically viable approach. So the so-called ISA per quali, which, as you know, in our country for our National Institute for Health and Care Excellence needs to be under £20,000 for a new intervention, was around about £12,000. So this does look, when you factor in all of those characteristics that I mentioned to you, that it could well be an economically way to go. But of course, we need to study it in more detail.
Yeah, that's actually really interesting. So when you say that it's economically viable, how do you think it'll affect us as surgeons if this were to come into practice?
Yes, so lung cancer screening is here in the UK and in some other countries around the world. It's actually a very effective screening program. I think that's beyond doubt. We already catch the upper part of the kidney in some of the people having lung cancer screening. And so we're already finding some tumours that way. We're seeing these people come through our practice. But of course, we don't see the middle part of the kidney or the lower part of the kidney. And in some people, you don't catch the upper part of the kidney either. So the way that we've been looking at this for the kidney side of things is that we're preempting the diagnosis of kidney masses that will come potentially at a later phase in some of these people's lives. So I think we're bringing forward the diagnosis. So ultimately, the workload is unlikely to be dramatically different. The aneurysm side, I mean, this is more for the vascular surgery community, but they're very interested in this level of findings. They would prefer to find these things at the smaller stage so that they can be monitored and managed in an elective fashion rather than having emergency aneurysm ruptures. So I think it just shifts the timing of intervention for these findings.
Yeah, okay, yeah, that makes a lot of sense. And then in terms of imaging of choice, do you see an independent kidney cancer screening program? And if so, would you still think CT scan is the best option, or would you consider something like an ultrasound as a viable option for screening the population?
Yeah, so I think it's very unlikely we're going to have an economically viable approach to scanning all comers as things stand at the moment. But of course, smoking, just taking kidney cancer on its own, smoking's not the only risk factor. Obesity is another one, for example. I would like to see refining of the risk stratification for this cancer and other cancers as well. There are options around things like polygenic risk scores and such like that we've seen in prostate cancer, for example, in the future. So I think it's always going to be combined or certainly risk stratified. In terms of the modality, actually, when we started doing work on this, I'd envisaged that we might use ultrasound and that we might do the work in conjunction with the aneurysm screening programs that exist in some parts of the world, which are ultrasound based. The challenges there are that currently aneurysm screening is only for men at a certain age. That's already got a negative element to it. It's actually quite difficult to teach ultrasound of the kidney region to non-radiologists or radiographers. And a lot of the people that do aneurysm screening are actually technicians that are taught simply to measure the width of a tube, which is the aorta. So it's quite different finding the kidney in an often obese male who may have a small renal mass. So that's quite a difficult technique. Hence the reason we went with something that wasn't operator dependent in the form of a CT. We've actually done quite a lot of work around automated analysis of the imaging reading of the CTs to try and reduce the burden of work. And also we know that the public, because we've done a survey of 1,500 members of the public, would prefer an approach that's bolted onto an existing screening visit. So that's another appealing thing around the piggybacking onto the lung screening.
Amazing. Yeah, that again makes a lot of sense. So I think my final question is around how reproducible do you think is it in other health settings? Say the NHS is a very public-dominated healthcare system, and as we know, there's a lot of private healthcare out there in other countries, and also kind of the low to middle income countries. How do you think this will affect them, and how would they be able to counsel their patients with your findings, for example?
Yeah, really important. So obviously there are nations where lung cancer screening does take place, and I think that's an obvious opportunity. My sense is that these types of approaches don't strike the same chord in privatized health systems like the US, because so many people end up having imaging done through private insurance, that it's a slightly different balance to a social healthcare system like the National Health Service. Interestingly, when you look at low and middle income countries, some of them have screening approaches for other types of cancers. So, for example, in the Indian subcontinent, there's some screening around oropharyngeal cancers, for example. And again, I think there are opportunities there for looking at the risk, smoking, etc., and potentially dovetailing it with some sort of approach like this. But clearly, we have looked at this from a UK and European standpoint, if you like.
Yeah. Brilliant. I think that's everything from my end. Thank you very much. This is a brilliant paper. I'd really recommend all our readers to go and read it. And thank you very much, Professor Stewart, for coming on today to our podcast. And I really look forward to any future papers and conversations we can have. So thanks very much.
Thank you, Nikita.
Wow, great chat, Nikita. That is very interesting. The idea of adding on a CT of the abdomen to patients having a CT of chest for lung screening, which is becoming a thing around the world. We know that there's a significant role for CT of the chest for high-risk populations for lung cancer screening. So bring the scanner down a little bit more and grab the kidneys. That's what they did in the Yorkshire study. What do you think? Has this got legs? Is this something that's going to be rolling out around the world?
I think this definitely has potential, I have to say, and having read the paper myself, I see their point, and they have data to back it, and they do make an argument that this is the pickup rate is comparable to a lot of different cancers that have screening programs in place already, in fact, better than some of them. So yeah, I definitely see the potential here. And like we know, kidney cancer, affects younger patients as well. And, there's definitely a case to be made to extend the CT scanner, as you say, down to the abdomen, especially if you're already screening for the lung. So yeah, it definitely has legs.
Yeah. Okay. Very interesting indeed. And I think as CT technology improves, lower dose CT, fast CT, etc., you might well say that. How often do we all see it in clinical practice? Anyway, it does come up once or twice a year in our practice that a CT of the chest for somebody who's having follow up for their melanoma or whatever will catch the top of the kidneys, and we sometimes will see a renal mass. So yeah. Very nice work. So congrats to Grant and the study team. And finally, a nice little segment that we recorded when we were in Madrid recently for the EAU meeting. As I mentioned earlier, the journal here at European Urology, we give out a few really quite prestigious prizes every year for the best paper in individual categories, one of which is the best translational paper. And we caught up with Dr. Laura Elst, who works with Martin Alberson, a previous associate editor and chaired the SCO, the scientific committee at the EAU, about her paper on penile cancer that won our top award for best scientific paper. So let's go back to Madrid and enjoy our chat with Laura about this. I'm here with Dr. Laura Elst, who's one of our big prize winners from European Urology this year. Laura, how are you?
Thank you. I'm fine. Yes, it was a pleasant conference. I enjoyed it a lot. Thank you.
Great. Yeah. So we're here at the EAU in Madrid where we do give out our awards. So you're at Leuven and you're doing a PhD, I think, in penile cancer with Martin Albertson.
Yeah, that's true.
That's true. So can you just briefly summarise the paper that you won this award for in European Urology?
Yeah, of course. So as you know, since 2016, penile cancer has been stratified into HPV positive and HPV negative cancers, but actually we don't know the differences in carcinogenesis between the two. And we know that HPV negative patients have a TP53 mutation in 75% of cases, while HPV positive patients have it in 10% of cases. So we hypothesize that TP53 might be a driver of poor prognosis, both in HPV negative and HPV positive patients. So actually we use single-cell RNA sequencing and T-cell receptor sequencing to stratify our patients in 3 groups instead of 2. So we had a group HPV positive without a mutation, HPV negative without a mutation, and we had a group with TP53 mutation irrespective of HPV status. And so we did all the sequencing work, and firstly we tried to validate the 3 groups prognostically. So we did stainings and we did a Kaplan-Meier analysis, and we saw that patients with a P53 aberrant staining actually had a poor prognosis compared to both patients with HPV positive or negative disease who didn't have the mutation. So this was actually a very important finding. And secondly, we tried to identify differences in carcinogenesis through single-cell RNA sequencing. And what was very interesting is that we found 3 different groups. So HPV positive patients without a mutation had a very immune hot environment. So we hypothesized that they would benefit from immunotherapy, but they also had like Nectin-4 and TROP2. So maybe they would also benefit from antibody-drug conjugates.
Yeah. Amazing.
Yeah, so that's a big finding, I think, for penile cancer. And then the second group, HPV negative patients who didn't have the mutation, had a very exhausted phenotype. So we saw a lot of PD-1, LAG-3, CTLA-4. So maybe we should try novel prospective trials with immune checkpoint inhibitors. And then the last group is a group with TP53 mutations, the group who had a very worse prognosis. In this group, we saw that there was a lot of epithelial to mesenchymal transition, so actually it's a very poor phenotype. We also saw a lot of angiogenesis, a lot of M2 macrophages, so very poor characteristics, a very immune-evaded phenotype as well. So in this group, it will be challenging, I think, but we need to look for combinatorial regimens. But that's work going on.
Well, yeah. It's an amazing bit of science and will really help our understanding of these patients and how we can plan future treatments. Certainly, I'm sure we'd all agree, deserving of the Best Translational Paper Award, European Urology 2025, which is quite a big deal for us. So congratulations,
Thank you very
Laura,
much.
to you and everyone in the lab at Leuven.
Thank you very much. Yeah.
You're welcome.
Thank you.
Wow, that was absolutely outstanding. Really interesting to hear. And even, translation science can be really difficult to understand, but I think that was, very interesting and definitely engaging. So congratulations to Laura and her boss, Martin. Great to see such, high quality work in the journal as well. What do you think, Declan?
Yeah, look, I totally agree. And of course, most of the work coming through European Urology tends to be clinical. But Alberto Briganti and all his predecessors, Jim Cato and Francesco Montorsi and so on, have always watched out for the best quality translational work. And it is great to see that, great to see young investigators doing that. This work is very valuable. And I must say at Leuven, where Laura did her work with Martin Alberson, they've always had a really strong translational culture there. So it's great to see that ongoing and to be awarded like this. So yeah, so for younger trainees out there, I do hope you enjoy that type of work, and please do submit to us to the highest impact factor journal in urology. We don't just do clinical. We will publish the very best translational work if it's especially like that, a really valuable penile cancer project that can change practice with the sort of findings that come out of that. So yeah, really, really, really nice work, and yeah, great to see Laura picking up that big prize at the EAU.
Yeah, absolutely. So I think that's it from us. And we really hope that you enjoyed this episode. And we certainly enjoy putting it together for you. So this is the European Urology Podcast. Please do subscribe, rate, and review us wherever you get your podcasts. And we'll be back next month with more highlights from the journal. And if you have any feedback, do let us know as well. And if you would like us to introduce something new in the podcast, then let us know. And and looking forward to next month.
Great. Thank you.